Good morning. Welcome to Lakeland Community College. I'm Kathy Walsh, the director of the Small Business Development Center here at Lakeland, located on the main campus across the street. The Small Business Development Centers are sort of a local arm of the Small Business Administration, so we're here to assist small businesses with any number of small business counseling issues, and we also hold educational workshops like the one you're at today. So welcome. I want to thank Barb Marlowe for helping us put this together with Randy Ostry, and this was a lot of coordinating and a lot of work, and it's hopefully going to be a wonderful event for everybody. And I also want to thank James DeRoche and Stuart Garson. They provided the breakfast this morning. So other than that, I want to introduce our moderator today, Randy M. Ostry. Randy has been an attorney for nearly 30 years and is currently serving as the Attorney General Mike DeWine's Director of Statewide Substance Use Education and Business Initiatives in the Heroin Unit. Randy advises the Attorney General on policy matters involving the current opioid epidemic, focusing on prevention education in the schools and business community. She also administers the office's drug use prevention grant and works with schools and law enforcement on curriculum development in prevention education. She is a former assistant Cuyahoga and Lake County prosecuting attorney with extensive experience litigating constitutional issues and advocating for crime victims. Her legal career includes serving as a commissioner of the Ohio Court of Claims Victims of Crime Division, appointed by the Ohio Supreme Court Justices, the former managing attorney of the Cleveland Regional Office, appointed by Attorney General Mike DeWine. Randy's national policy work in crime victims recovery and local education and advocacy efforts with the opioid addicted enhance the heroin unit's reach into the courts, the schools, law enforcement agencies, and now in matters affecting businesses, their employees, and how to train, reach, and treat them as associated costs rise and the health of the workforce declines. Randy, welcome.
Thank you, Kathy, and good morning, everyone. It is an absolute privilege to be here today. And thank you, Barbara Marlowe, for helping make this the brainchild of the small business community here and the partnership with the Lakeland Community College at the Holden University Center. It's a spectacular venue. I am formerly of Lake County. I just moved to Bracknell about, 7 years ago or so I could be close to Lake County. And I see some friends here from around the state and also locally, the work that we have been able to do under Attorney General Mike DeWine. I have been a part of the heroin unit for a couple of years now, and one of the things that I do, as Kathy said, is work with the business community. We have traveled the state listening to businesses, listening to the struggles, listening to how it affects the economy, the tax base, how it affects families, and it is important. This is an important issue as we go forward. Ohio, as we all know, is at the tip of the spear with this, and we need to deploy some creative solutions to really bring solid help to people and help the businesses that are struggling. We have a great panel lined up for you today, and it is my great privilege to introduce our first speaker, which is Dr. Randy Jernasik. He has great Lake County roots. He's a graduate of Mentor High School and currently serves as the Chief Medical Officer and attending physician at University Hospital's Ahuja Medical Center. He is the chairman of the UH Patient Safety Opioid Committee and also the chairman, which he's going to discuss in his remarks, of the newly formed Northeastern Ohio Hospital Opioid Consortium. An interesting fact, he actually served in Beijing, China for about 3 years as part of the United Family Hospital in China. And without further ado, Dr. Jernasik.
Good morning, everybody. Is that working? Good. Well, so I usually like to walk around the room, and I'm told that I have to be kind of anchored here, so we'll see how this goes if I start to wander. Looking around the room and meeting a number of the folks this morning, I've got to say I was a little bit undersold on what the audience was going to be. I asked who am I going to be speaking to and what would they like to hear. And they said, oh, it's going to be a great crowd. And actually, that's not true. It's a phenomenal crowd. Look at the folks around the room and just the talent and the things that you all represent. So I'm really proud to be here this morning to be talking about something that I've become very passionate about. I'm not a psychiatrist. I'm not a addiction medicine physician. But what I am is I have a long history of both primary care and emergency medicine. And I've seen the opioid crisis from those perspectives and how devastating it can be from many different levels, and seeing it affect patients directly and families in our communities. I've also been a physician leader for a number of years, and as chief medical officer, I see that from a very different perspective, and so I was very proud to be asked to lead the UH response across our system to the opioid crisis, and it's become a real passion for me, and I'm hoping today to share with you to build the case that we are in a crisis, that there's hope, and that we have a lot of opportunity to work together to help solve this crisis. So look forward to sharing with you over about the next half hour some of what we have today. So that's me, and again, I'm really excited to be talking not only about it as a physician, but as a community, or as a physician leader, but really as a member of this community, because it hits all of us so hard. Some objectives, I've already talked a little bit about that, but some basic recognition of the opioid crisis and what that really means for us. I think you'll find some of this to be very shocking. I know I read a lot about the opioid crisis, but never put it into context until I saw some of these numbers. To understand, I'm going to share a little bit about what University Hospital is doing, not as an advertisement, but just to show kind of what I know in a little bit of detail and ways that we can all communicate, because this is not one of us working together in one business or one area. Really, I hope to tell you that this is a community response we have to have. And then I always tell, when I actually do some of this presentation to my physician colleagues, they want to know, well, yeah, where are we going and how are we going to get there? And I will tell you, I was just in Baltimore a few weeks ago, and there is no clear destination of where we're going. Nobody has a roadmap to figure this out around the country. So we are going on a journey without a roadmap to help solve this, but we can't stop, and we can't wait for that to occur. So I'm going to share a little bit of that with you also. So, 2016 in October, the U.S. Senate Finance Committee called Ohio the face of the nation's opioid epidemic. Not a surprise, but a shock, and not a place where I think Ohio wants to be remembered as the face of the opioid epidemic. But what does that mean, and what is an epidemic, and what's an opioid epidemic mean? A lot of people think of this as the opioid epidemic, right? The rock stars, I guess I could put Tom Petty up here and a few others recently. But as a practicing physician, these are not the people that I see. These are the people that I see. These are the folks, these are real folks, people, and all the pictures you'll see are people that have been a victim of the opioid crisis. But when I look at these pictures, I see neighbors, colleagues, co-workers, friends. You could even see an uncle, a brother, a sister up there. You can even see a little bit of yourself up there. These are real people. And this is what our community, and this is what our opioid crisis looks like. So to define an opioid crisis, first you have to define what an opioid is. I promise you that this is going to be very little. This is probably the only clinical part you're going to hear from me here, I hope. And call me out if I do get any more clinical. But what is an opioid? You look down the one side, there's a whole list of medications, generic and name brands. Many of them are prescription. Most of the drugs on there, I can write a prescription for you right now. But some of them are illegal, like down on the bottom, heroin. But all these are opioids and work in very similar ways to what we'll talk about. But what is the opioid? Well, it's a class of drugs that block receptors in your nerves that stop signals from going to your brain, like pain signals. That's actually pretty good, right? If you're having surgery, you want that. But at the same time, it also can produce a bit of a euphoria. And, in a time of crisis and a time of pain, that's actually not a bad thing either, right? The problem becomes is that over time, if you take it at high enough doses, it also stops your brain from realizing you have to breathe, and it shuts down your breathing, and you die of suffocation. And that's where all the opioid overdoses come from. And that is obviously why we have this crisis. It also leads to the addiction aspect that we'll talk here about that leads to that. So some definitions, I thought it was fair because there's a lot of definitions out there. Tolerance, we all hear about tolerance, but this is really what a user needs to get more and more substance to receive an effect. And what I want to be really clear about is we are not just talking about addicts. I remember growing up and my grandma always telling me, don't go downtown Cleveland, there's all these addicts down there, right? That's where I got in Menor. But this is also, you build tolerance if you're using these medications for pain. You got chronic cancer pain, you have to have more and more oftentimes to get the pain relief that you're looking for. It builds up tolerance, and that's how these drugs work. Physical dependence. You need more and more of the drug, or else you start to get withdrawal symptoms from it. That can happen if you're using it and abusing it as an addiction. It can also happen if you're using it for chronic pain for legitimate medical reasons. Can start to lead to psychological dependence, where I need the drug or else I'm not feeling like myself. That's a little bit different than not having the pain. And this is where we start going down this slope. I'm not an addiction specialist. We got other folks that are, but really just this is to start setting some definitions for you. And then withdrawal, physical or psychological. You start to have a reaction when you don't have that drug or medication with you, regardless of the reason why you're using it. So this pathway to addiction, this is just a very simple use of this. You start to use the drug, again, whether it's recreationally or for legitimate medical reasons. You start to build a tolerance. You need more and more to produce the effect that you were originally getting. You start to get dependent, and so that means you start to get withdrawal from it when you stop having the drug. Guess what that means? You want more of the drug. And pretty soon, over time, and not for everybody, not everybody becomes addicted, but over time it can lead to addiction where you lose your control of that habit. You got to get more and more of that drug for whatever to fight that withdrawal and to help with the symptoms or the feelings that you were trying to use for the medication for. I kind of like this cartoon a little bit better. This shows the kind of normal balance. You got a lot of things going on in your head that you're thinking about. Your family, your food, your television, your school, your work, your kids. And over time, as it starts getting down that progression of the previous slide, that's all that's really going on. Your thoughts are more and more, how do I get that connection over time? I don't know about you, but I love my ice cream, and I can't turn that down sometimes. And I can't imagine how overpowering this can be for people, and just put it in a little bit of perspective. How fast does it take when you go to bed? Nobody goes to bed wanting to wake up tomorrow as a heroin addict. I can tell you that. Nobody does. But 6 to 12 hours, when you start getting these symptoms of nausea and vomiting and bad symptoms of withdrawal, when you wake up in the morning, the first thing you're starting to think about is, how am I going to get that next dose so I don't go through withdrawal? Because why? Because it's scary. It's the worst flu you've ever had in your life. Think about that times 1,000. It's really bad for folks. And so you can see why this is a cycle people get on, and it's very hard to get off, whether they're on it for legitimate reasons, i.e. medical stuff, pain control, or start to use it. This is a disease, just like anybody here that's a diabetic. You said, I want to be a diabetic tomorrow? No. You said, I don't want to be a diabetic tomorrow? That's true. Most addicts do not want to be an addict tomorrow, but we got to really start thinking about this differently. It's not a choice, unfortunately. And we'll talk a little bit about that here later on. Well, let's put it a little bit into context, if you will. So I told you a little bit about, I said an opioid epidemic. I talked a little bit about what an opioid is, but does that mean we have an epidemic? And I'm hoping that over the next few slides, you're going to agree with me that we're in an epidemic here. This is a death toll. This is across the United States alone. Mind you, the United States only, not internationally. And this is the curve from 2002 to 2016 of the deaths that have occurred across the country. And you can see that that curve is nowhere near going down. It's going in the wrong direction, right? 42,249 deaths in 2016 in the United States. We're starting to get some of the real numbers from 2017. That lags a little bit, and I didn't update this slide, but the numbers, I will tell you, have continued to go along that trajectory of that curve. If you think about that, what would happen if a 747 dropped out of the sky tomorrow? What would happen if one every 3.5 days fell out of the sky in the United States tomorrow or over the next year? That's what that represents, is 108 jumbo jets, or one every 3.5 days. In the United States of America, what would we do if that was happening here? That's what's happening in the opioid crisis today. So I trained during the AIDS epidemic, and I wanted to put this into a little bit of context. This is, I took that 42,249 and I compared that to an AIDS death statistic that happened, and again, this was just in the United States. We have now surpassed the number of deaths at our peak year in the AIDS epidemic in the United States. We were at 41,699 back in the 1995's time, and we've now surpassed that. And as I can tell you before, that curve is not going down. Look what happened to the AIDS curve, how we got ahead of this. Some misconceptions. Who does this affect? About 58% male, 42% female. Not surprisingly, some of the younger folks out there in the community, 69, 70% in the 25 to 54% age range, but I find the shocking statistic at nearly a quarter are in the 55 plus age range. I have taken care of patients in their 80s who have been utilizing these medications and have been addicted to it. Well, Ohio has the distinct honor of being the face of the opioid nation, and we have some other dubious honors also. Up until not too long ago, if you saw on my first slide, it was very on purpose that slide was very Caucasian. Because up until several years ago, that this was really affecting much more the Caucasian part of our communities. And Cleveland has one of the dubious reputations as one of the epicenters in the country of where the African American community is growing very rapidly in this in this crisis. And so therefore it's really hitting, there's no boundaries to this epidemic and this crisis. I'm sure nobody has missed this. This was out in the press a few years ago. I was actually in China visiting, and this made the newspaper there. Shocking. These grandparents that were found in the car both passed out with the child in the back seat. But overdoses, 42,249 deaths are tangible, right? I can count a death. I can count when somebody comes into my emergency room and dies. I can count somebody at the morgue. What I can't count is all the other significant impacts on life outside of that. Over 2.1 million addicts in the country, and that's just not the addicts that are affected, correct? It's the losses of family. It's what happens to the family members. It's the loss, and this really hits home to you, right? What happens to businesses? I was talking to our snowplow driver and lawn guy the other day, and he was saying he just can't hire people right now to drive because of so many people that can't pass drug tests. I see a lot of heads nodding. You all see this, right? The economic effect of this and your ability to run businesses and to lost productivity, in the healthcare society, in the sector, we're seeing increasing diversion of drugs. It's a huge issue in healthcare, but that's not the only area where we're seeing this affecting our society. I have another slide that I'll show a little bit more on that in a moment, but this is just bringing it down closer to Ohio. This was, again, a little bit outdated, 4,235 deaths in just the state of Ohio. And again, this curve goes up as dramatically as before. But what I want to do is I like this curve a little bit better. This is the same blue as you saw on the previous one, the deaths. What this has is in the yellow are all the overdoses that don't lead to deaths. So about 5 to 6 overdoses leading to 1 death. This doesn't count for all the other people that have the addiction. And this is where it's projected to go in Ohio if we continue to go. Actually, there's a revised curve. It actually looks worse now with last year's numbers in, but a revised curve shows we could potentially be reaching 18,000 deaths in the state of Ohio alone if we continue on this trajectory. So the overdose rate per capita, per county, this goes to show you 2011, 2014, and 2016. As you can see, doesn't take a lot to read that we are in the epicenter of the crisis in the state, along with down the southwestern part of the state. This slide, I now think about it, I just added this last night. I should have put it in a slightly different order, but this goes back to that economic issue. From 2001 to 2016, $1 trillion impact on the country when you look at both healthcare costs, right? What I see in the hospital, the ICU, the neonatal, the NICU, the children born with addiction, to lost revenue, lost employment, lost productivity out in the workforce. $1 trillion it's estimated, and look at that curve at the end. In 4 years, it's projected to be half that again, $500 billion. I hope at this point I've convinced you of what an opioid is and that we clearly have an epidemic, right? Hard to ignore those numbers. But this is the part in the talk I always like to stop and say, wait a minute, as a physician, I remember our president at University Hospitals, Mr. Tom Zenny, asked me back in September to lead the opioid response for university hospitals. And I said, okay, well, what does that mean? What do we want to do, and how do we want to approach this? And I'll tell you, the initial knee-jerk reaction everybody has is to just stop prescribing the pills, right? But this is why I want to stop here and recognize that for as life-damaging as potentially these medications have been, they're also life-saving, right? Modern surgery, modern advances in medicine could not have been had without these medications. I think of the patients that I care for who have chronic cancer pain who are living lives because of these medications. And so the idea that we have taken and the approach that we have taken is that we have to respect these medications. We do risky things every day in healthcare, deliver babies, surgery, whatever we do, right? We have to look at that and be respectful of what the risks are with these medications and to use them and prescribe them appropriately and make sure they're only getting in the hands of the people who need them when they need them. That's a lot more difficult than just stopping and writing them, I have to tell you that. But I always like to take the pause and remind people that these medications are important medications. I told you everybody in this slide is real. So causes of the crisis. I've sat in a number of different communities and different settings, healthcare workers, et cetera, and I've talked about what's the reason for the crisis. Why are we in this crisis? And there's just some words up there that have been thrown up there, and the answer is, everybody's probably right. If it was one simple thing, I always say if we had one magic pill to solve this crisis, we would have given it. And there's a ton of different reasons why we're in this crisis that we are in. And my message to my physician colleagues is, I don't really care at this point. We have to own it and we have to solve it. We have to help lead this. It's true that 75% of heroin users started off with a prescription medication. Now, that might not have been one I wrote for you. It might have been one you got off the street somewhere that got diverted. But the fact is, prescription medications are part of this. They're not the only part of this, but they are part of this. And where does our community go to when they're sick? Doesn't matter. When they're sick, they come to healthcare. And so and my challenge to our hospital system and to our physicians is for us to be leaders in this crisis. But we can't do it alone, and I'll share that with you. The vast majority of addiction overdoses are related to prescription opioids. Again, not necessarily the ones you were written for. They get diverted frequently, and I'll share a little bit about that with you here towards the end. 75% of heroin users, I mentioned. There's a lot of concern out there that the government had, the Medicare Centers for Medicare and Medicaid had actually tied hospital compensation to patient experience, which also included how did I control your pain? And I will tell you, I can't get your pain to zero all the time, and I shouldn't be driving it that way. Interestingly enough, they've recently changed that, which is good. And we all have heard about pill mills, but I'll tell you, that's not the kind of leading issue here. Major pharma couldn't really kind of have a conversation without talking about that. A $17.1 billion industry nationally, billion dollar. There's a lot of things, and I'm not going to try to stand up here and argue whether it was legitimate or not, but I would remember in my training when OxyContin first came out, I dated myself for any of you that might be physicians in there, but in the room. But I remember being told, doctor, you want to treat your patient's pain, don't you? Absolutely. Who would say no? Which physician would want to say no to that? And then I remember being told that there's less than 1% chance of addiction of these medications because they're new and proven to be safe. I mean, right? Every doctor out there that I know wants to help somebody. How can you argue with, I can help somebody now that I couldn't help before? And so it was a bit misleading. The drug cartels, everybody thinks about Mexico and South America, but I'll tell you that I worked in China for a number of years, and so I have strong connections there, but the Chinese synthetic fentanyl that is now absolutely devastating Ohio, again, another horrible place where we are leading the country. But you can get on your smartphone right now, you can get on your computer at work or at home. I wouldn't recommend that you do either of those, but you can order fentanyl from those places and have it shipped via the U.S. Postal Service nicely to your home, kind of like the Amazon of drug dealing, right? But that's certainly part of this, and this is what's killing a lot of people right now. And then the list can go on. And like I said, you know what? The answer is probably yes. There's all kinds of things that are leading towards that, and we've got wonderful folks like Randy here and what they're doing at the Attorney General's office and that trying to lead different aspects of this, but it really takes a community to lead towards this crisis. I like this curve because this really kind of summarizes, I think, the last one, and this talks about how the U.S. consumes more than 80% of the global opioid production, while we are only about 5% of the world's population. That's just stunning. And I have not only worked in China, and I led a hospital in China for 3 years and practiced there, but I've also done work in healthcare in Africa and South America, and it is really a different story about how we approach opioids. It's shocking. So just very briefly, again, I'm not here to be a commercial for UH, but I want to tell a little bit of a personal story about how we're trying to lead this and what it is. And I'll tell you, when we first started having these conversations, we knew we had to do something. We knew we had to step up. And the challenge was, we want to be leaders in this area. And I was just in Baltimore because we were recognized as leading some of this work nationally. Tom Zenti, our president, gave the keynote speech at a symposium. But this has really been a challenge, and it's been our evolution has been how we've been thinking about how we want to do this. And I tell you, early on, we thought we could do this, and we were just going to stop writing for medications. And we were very naive early on because these medications are so important. And we can't do it ourselves. Really, we have to partner with folks throughout the communities and throughout the region, and we are doing that. The Northeastern Ohio Hospital Opioid Consortium, as was mentioned in my intro, is, I think, fairly unique, right? You see up there the university hospitals, the Veterans Administration, Cleveland Clinic, Metro, and St. Vincent's, all considered competitors. But as Tom Zenti said, this is not about market share. This is about what's doing right for our community. And I'm fortunate to be the inaugural chair. We just got this up and launched over late October, November. And I think we're actually really starting to get some traction under our feet and coming together about how we go ahead and approach this, because frankly, patients go back and forth between all of our systems, and we should be sending the same message. And so we're working on those areas to partner. Within the university hospitals, I told you initially we were looking at opioids, and this is not quite ready for prime time what I'm showing you here yet, but it's really where our evolution of our thoughts are. It's no longer just about opioids, it's about how do we manage people in pain, right? Whether it's physical pain, whether it's psychological pain, or combination, which is oftentimes the case. But we're really trying to look at taking a holistic approach to this, and we're developing an institute, which is what we do to address patients in pain no matter where they are. Our ICUs, our surgical centers, our family practice centers, right, wherever they present, and try to take that holistic approach to these patients. And I was the interim director to get this up and started for this, and I've actually, because of a few changes in my career that I've been doing lately, I've actually handed this off to somebody who I think is a little bit better suited to do this. But to show what we're doing, we've actually put a psychiatrist involved in running this institute as opposed to an anesthesiologist, because I think that mental health component of what we do for our patients in these areas is so important. And these are just some of our guiding principles. The highest quality care system-wide. Mr. Zenti said everywhere we touch a patient, and I mean everywhere, and that's where we're trying to shoot for. That's a big, tall order, and that's what our institute model comes from. Looking at diverse departments across the system. Believe it or not, it's not very uncommon in large institutions where people don't always communicate very well at that good, because we're geographically spread out. How do we make sure we're communicating well to get that good handoff to the patient in the right place? Focusing on making sure that this is the best patient experience as we do this. System-wide, I mentioned this, and to me, the important part is community, community, community. So how can you help? And I put this in here fairly generically because I knew a little bit about the makeup of the audience. I said a phenomenal audience in the beginning, but I made this a little bit more just kind of community, because I think this is, you're going to hear from some other folks on the panel here today, but I wanted to be, just as a member, I'm a member of your community too, right? And so how can I help, not just as a chief medical officer and leading the opioids, but how can any of us help? And I'm going to go through a couple of these slides, and I'm almost done here. Recognize that it may be in your neighborhood, your place of employment. Take opioids only when you need them, dispose of opioids properly, advocate for more access to addiction treatment and mental health, and be a part of the solution. It takes a community. We can't do this by ourselves. So I'm going to touch on a couple of those very quickly. Recognize that it may be in your neighborhood, your place of employment. One of the biggest issues to this is the stigma, and trying to make sure you did not choose to be a diabetic, you did not choose to be an addict. Yes, maybe you did take the medication and recreationally the first time, but most people do not continue to do that. We need to get rid of that stigma, and we need to help support this. One of the things that we're working on is what happens when it's your state license that's involved in it, and how do we help folks, because we want to make sure that we are keeping them, caring for patients safely and appropriately, but not stigmatizing them in the workforce. More than 1 in 5 Americans are affected from this crisis, and when I say that, it's either through personal addiction, a close family member. I'm not talking about your 8th cousin, or a very close friend, and I'm not talking about the pizza guy who delivered, I'm talking about a close person in your inner circle, are effective with this. I think it's probably more 1 in 4, but recognize it's around you. I live in Bainbridge. It is there. Think about this as a chronic disease. As I mentioned, diabetes, it's not your choice to be a diabetic. It is your choice to control your diabetes. Heroin users do not wake up wanting to or go to bed doing it. They wake up because they have a withdrawal and they need to be taking care of this illness. Ask questions if you suspect a problem. Sometimes that's just the beginning to make sure you're getting it out. How can you help? Excuse me, talk to your doctor, dentist. My uncle had surgery the other day. He's not a chronic opioid user. He only used opioids just in the first hour or two after the procedure. He was in the hospital for 2 days afterwards, and they sent him home with 90 Percocet prescription. I said, I'll take that. Threw that away. Be an advocate. Talk to them. I had a friend who talked to her dentist and said, why do I need 20? Can you just send me home with 3? And they did. So advocate and talk about that. We have a hard time predicting sometimes what you're going to need, but have that dialogue. As a physician, I ask you to do that. Are there other alternatives? We have our Connor Integrative our Connor Integrative Medicine program at UH, which focuses on imagery, yoga, acupuncture, all kinds of other issues that, while if it may not take away your need for an opioid, hopefully it greatly reduces your need for that. And that's very tightly interwound in our Pain Institute model that we're developing. Do you really need so many pills? I mentioned that. Know the RX. This is actually a local Cleveland thing, and there's a website there that you can have, but they have some really good, interesting information on there about kind of things you can do as just a member of the community, regardless of what your profession or background or skill is. And is no pain an expectation. I will do everything to take care of your pain when you're under my care, but I also have to recognize a broken leg will sometimes be a little bit uncomfortable. Zero pain is not reasonable, and we have to change that conversation. More ways you can do: dispose of your opioids properly. I talked about many of the drugs that are out there are not out there because I wrote them for you. What we find frequently is they sit in grandma's medicine cabinet and somebody comes by and they pilfer them and they end up on the street. So dispose of them properly. I'm sure the fish in Lake Erie might like you to flush them down the toilet because they'll be happy fish. But I ask you not to do that. There are ways to get rid of them, and this one is from Cuyahoga County. I wasn't quite sure where the audience exactly would be. Lake County was probably I should have gotten, but there are similar things from Lake County that there are safe drug drop boxes around. We have people bringing them in all the time. It's hard because of legal issues. I take them in. What do I do in my office? So we try not to get our doctor's offices to be taking these medications because obviously they're a risk for being pilfered and taken and stolen and that. But there are safe ways you can dispose of medications out there. And then advocate for more open access. I know we got representation from the Adams Board here. I can't say this enough that over 50% of folks who have addiction also have mental illness or issues with depression and other kinds of forms of issues that they need to be addressed in that area. So break down the stigma. Advocate for mental health access in our communities. It's a real struggle, and we really need to do that. Finally, I don't get royalties for this book, but I always like to talk about this. It's called Dreamland. And it's a well-written book. It's a couple years old. It's already outdated because it doesn't talk about the fentanyl. But Dreamland, I won't tell the story totally for you, but Dreamland comes from a park down on the southern Ohio border along the Ohio River, of a park that used to be where families did a lot of their recreation, and it's no longer that place. And it talks about not only nationally, but it focuses a lot on the state of Ohio about why we are the epicenter of this. And I think it's a fascinating read if it's something you want to educate yourself about, because it's stunning. Some of the things I trained during a lot of what happened, and looking back, I trained in Columbus. Looking back now, we didn't really know what was happening, but looking back and seeing the chronicle and how he puts this out, I start to say, yeah, I recognize that now. That was what was going on. So it's a great read if you're interested in this. And finally, this is Tyler. Tyler's grew up in a suburb of Columbus. And Tyler, I struggle with this picture because this is not personal, but I interacted with this family. This family does a lot of speaking around the country and really tries to help with this. But Tyler was a promising young college student athlete. Tyler and one of his co-athletes on his team at collegiate level both died of opioid overdoses. And his family has made it their mission to get out there and spread that word. So thank you for your time. Thank you for your interest. Please be part of the community. Please be part of the situation that helps solve this. We are not going to do this alone. And I'll be honest with you, somebody once told me that they don't think our curve, that curve I showed you, that death curve, is going to start plateauing till at least 2020 because of the trajectory we're on. But we can't hide from this. We've got to do this together, and only together will we solve this. Thank you for your time.
Thank you, Dr. Jernasik. That was absolutely excellent. Our community is very fortunate and privileged to have someone like you with your the caliber of you as a person, the caliber of you as a professional, and your experience leading up as the Chief Medical Officer for the Hoosier Medical Center, truly. So thank you for the information. Thank you for your passion and sharing it with us today. Our next speaker is Karen Pierce, someone who is very near and dear to me in my work professionally as we travel the state. Karen Pierce is the Managing Director of Policy Development and Training for a company, a local company of Ohio called Working Partners. Working Partners is not only a strategic partner and alliance with the Ohio Attorney General's Office Heroin Unit through our business work, but it's a training and consulting firm specializing in helping workplaces minimize the risks associated with substance abuse. Karen has served as the director of the Drug-Free Workplace Community Initiative, which is a private-public partnership with the Ohio Department of Mental Health and Addiction Services, to address the economic threat of substance abuse by employees and job seekers in our state, which is the absolute heart of what this seminar is about. Karen has worked in the alcohol and drug profession since 1982. I consider Karen Pierce and her colleague Dee Mason of Working Partners really a statewide treasure in this arena. Karen's devoted the past 25 years of her career to drug-free workplace issues. She currently serves on the board of directors of the Prevention Action Alliance and the Alcohol Drug Abuse Prevention Association of Ohio's Prevention Think Tank. She has received several distinctions for her work in the prevention field, including the Alcohol Drug Abuse Prevention Association of Ohio's Excellence in Prevention and Prevention Advocate Awards. Interestingly, we just partnered together with the Ohio Chamber for the Ohio Employer Opioid Toolkit, which is a free online set of 5 modules that offers free of charge to any business in the state of Ohio very solid, practical steps you can take as a business owner, which includes policies, procedures, second chance agreements, and PDFs that are drawn down. Hopefully Karen will be able to share that with you, and it's found free of charge at ohiochamber.com, a partnership with Working Partners, the Ohio Attorney General's Office, and Anthem. And without further ado, here's Karen Pierce.
I always get nervous when she says how long I've been in the drug and alcohol field. It's been a really long time. I started out doing treatment work, and I was terrible at that. Thank you to all the treatment professionals out there. Came with your organization. I just was not great at it. And I started doing prevention work, but it was back in the Just Say No era where we really didn't have a lot of evidence behind us to really know what we were doing. And that's changed a lot, but I have devoted the last 26 years to doing work in the workplaces. And I got to tell you, I'm incredibly biased, but I really believe 2 very powerful places we can wrap our hands around this issue is in my family. I really believe I had a lot of impact with my 2 children, and in the workplace. Businesses, you are powerful to be able to address this issue. How many of you in this room administer your organization's drug-free workplace program? Handful of you? Okay. Before I forget, I never mentioned resources that I bring. So, opioid infographic out on the table that talks about workplace-specific statistics, an infographic about the Ohio Chamber's toolkit. I'll talk a little bit about that, but make sure you grab this that gives you information on that. I want you to kind of put your workplace, your business glasses on, because we're really going to be looking at this issue really through the eyes of business. I'm giving you some statistics also. Hopefully not too many of them will be duplicative, but I really want to look at workplace in particular. So let's look at a couple things. First of all, working partners. Randy already mentioned this. We're a small training and consulting firm. We do a lot of projects, but a lot of our work is geared directly with the employer to help them minimize risks associated with the harmful use of substances. I do need to tell you, coming out of this shoot, that when we look at drug-free workplace issues, it really is a combination for me of things that are legally sound and things that are operationally sound. So particularly with prescriptions, which we're going to talk about in a moment, the legal side of that, we have to be respectful in the workplace about what we legally can and can't do around prescription medications. And equally, we need to be sure that things are operational. So a policy may say, legally, here are the situations in which I, as the employer, can ask you what you're taking or expecting you to take me. That's the legal part. But the operational part is, okay, if I have a supervisor out on the field and the employer comes up and says, hey, supervisor, here's what I'm taking. I thought you should know. I think I'm supposed to tell you. What's this supervisor supposed to do with that? Operationally, how does that look? I will tell you loud and clear that I am not an attorney, so I'm not going to be speaking at the legal issues. I'll talk more operations. I do have a legal partner that works with Littler who makes me tell you loud and clear a 3-bullet slide disclaiming that I am not an attorney. Any questions about that? This truly is just for informational purposes. If something that I say makes you wonder how it applies to your workplace, that's when it's appropriate to pick up your phone and consult with your attorney on some of those legal issues. Disclaimer, done. I need to start with the big picture first of all. We're going to talk and zero in about opiates, but I need you to take a look at the big picture of harmful use of substances on the workplace right now, all right? These are not workplace specifics. This is in general when we talk about who is using illicit drugs and what is the trend right now. When you take a look at 12 and older, so that's everyone that took the survey, the question was, have you taken an illicit drug, including marijuana, in the past month? 12 and older, you'll see right now 10%, that number is going up. 12 to 17, the number is going down. Why is that? People typically say, well, prevention. Well, it's more than prevention. It's evidence-based prevention happening in the schools, et cetera. But look at the employment age. When you look at 18 to 25, 26 or older, again, those numbers are going up. And that's an illicit drug in the past year, or past month. We know that 70% of people involved in the harmful use of substances are working. They're not hanging out in the streets, they're working. Now, there is a data source. Unfortunately, I don't have a lot of data sources that look directly at workplace. But the one data source I do have is to take a look at drug test results. It gives me a little bit of a fingerprint of what's happening directly in the workplace. Let me give you a couple of things. First, the bad news. I will tell you that Quest Diagnostics, are you familiar with Quest? Obviously, for medical testing, also one of the largest providers of workplace drug testing. When I started in this field in the late 80s, if you take a look at the chart and look at the rate of positive tests, it has been phenomenal that that rate has decreased significantly from the late 80s when they started collecting the data. We saw a little uptick in 2003 with the rate of positive tests. I'm not sure why that rate went right back down. But in 2013, 2012, it was at a 30-year low. 2013, we saw the second uptick that they'd ever seen since collecting the data. And that was an increase of 4.3% positives. The first year, this had never happened before. 2 years in a row, increase of positive tests year over year, another 9.3% increase. Third year in a row, fourth year in a row. We've never seen that. So when Randy talks about employers across the state that are saying we can't find workers who can test negative, we've got the data to support that. Unprecedented increase. The research just came out last week about 2017. It has leveled off. So we didn't see an increase in 2017, but this is unprecedented. So the first question you have to ask, I think, are, Who are the culprits? And this may be a little surprising to you. Who are the culprits, or what are the culprits? What drugs are causing this drastic increase? Hang on, because we're not going to be talking about opioids quite yet. Number one is marijuana. The rate of positive marijuana tests increased for the 5th consecutive year, and there are striking increases, as quoted by Quest Diagnostics, in those states in 2016 that put recreational statutes into place. But we are seeing an increased marijuana positives. Cocaine increased for the 5th consecutive year. 15 to 16, we saw a 12% increase in the rate of positives, and then another 7% last year. And look at meth. I do need to land on this one for a moment. Methamphetamine increased between 9 and 25% last year, and there are some regional trends. Guess where the danger spots are? Ohio, Indiana, Illinois, and West Virginia, where we've seen a 167% increase in positive tests for methamphetamine from 13 to 17. So one of my messages here is we really need to take a look at big picture. There are a lot of things happening in the workplace that are a little frightening. So you say, okay, well, what about opiates and opioids? Let's talk about that. Of course, that's why we're here. I have to start with a little bit of good news if I can. And that is, good news is that when you're talking about particularly prescription medications, as it relates to the workplace, and please understand that some of the workplace trends might not mirror community trends. So I just want to focus, we've made some progress in the workplace as far as prescription pain medications are concerned. Overall, Quest Diagnostics number again, rate of positives. Overall, the rate of opiate positives have decreased by 17%, and that was 16 to 17. Oxycodone decreased, hydrocodone, which is Vicodin, decreased, hydromorphone decreased, and even heroin decreased the rate of positives a bit. You can't help but wonder, okay, what can we hang that on? Because we want to do, if we know some things work as far as being able to change the milieu. Some things do work. We're doing, Ohio, I think, we may be a leader in the problem, but we're also a leader in the solutions as well. Let me mention a couple of initiatives. One, you probably are familiar with the ORS reporting system. ORS is a system where the pharmacies will register what a patient is getting, the drugs. Doctors can go in and check ORS. There has been, over the years, a 4,900% increase in ORS inquiries, meaning the doctors are going to check. 28.4 decrease in the opioid doses dispensed, and we've seen a 88% decrease in doctor shopping with prescription meds. Is that taking care of the whole problem? No. You ever been to the county fair and played whack-a-mole, where you hit one mole on the head and another comes up? We've seen that with some of the illicit types of opioids and opiates, but we are seeing some changes in what's happening with doctor shopping, etc. The Bureau of Workers' Compensation, I'm not sure if you're going to speak about this, but in 2011, they took a look at their workplace data and realized from the prescriptions that they were funding to employees that, what's my number here, 8,000 people were dependent on opioids from the medications that were paid for by the Bureau. They put a pain management program into place, and that number has been cut in half as far as what employees are using. So we are seeing some areas of some progress. Quest Diagnostics, hang with me with this long quote, but they say that the depth of our large-scale analysis supports the possibility that efforts made by policymakers, employers, and the medical community to decrease the availability of opioid prescriptions and curtail the opioid crisis is working to reduce their use. I do believe we have to look at some things that are working so that we can model more programs to see more success. But, of course, there is some bad news, and I don't ever know whether to start with the bad news or the good news first. But the bad news, the overdose deaths are out of control. We know that, especially related to illicit drugs. Couple of statistics nationally, the rate of overdose deaths up over 14%, leading cause of accidental death. In Ohio, our death rate was up 39% between 16 and 17, and that makes us only the third, we had the third largest increase among the states, number 3 on the list of increases. 14 people a day. 80% of the folks that were involved in overdose deaths had a history of prescription drug use, including opioids. And the impact to the available workforce, because I really think that's significant when you're looking at employers. You can look at applicants, you can look at current employees, but then you have workforce potential employees. And if you just take a look just at the ages of the people in Ohio, they are of employment age. 750 people last year in 2016 between 44 and 54, 915. So people that could be in the workforce that are not because of overdose deaths. A couple folks at OSU doing some really interesting work trying to measure the impact of opioids on the workplace, quoted saying one way of looking at the estimates for opioid abuse and dependency is that it could account for 1/3 to more than 1/2 of the decline in workplace participation since 2017. That's a very significant impact. And when you look at that available workforce issue, plus employers saying we can't find applicants that can test negative, we've got some issues to deal with. Financial implications, there are lots of those. I'm just going to mention a few. There are a few more on the opioid infographic here. A study that just came out was taking a look at how much employers are spending on prescription opioids, and that spending actually is down. Interestingly, however, the spending for treatment, what employers are paying for treatment, increased sharply. And another interesting thing about the statistic is it wasn't necessarily the employer that was going into treatment. Over half of the costs were associated with what? The employer's family members, children going through treatment. Again, our workforce of the future issue. Overall, the cost of the nation's opioid crisis has exceeded $1 trillion. You probably read that not too long ago, and the doctor mentioned it a moment ago. So what's an employer to do despite the current drug trends? And I think this is really important to take a look at that, is that there is an antidote that workplaces can administer to address any kind of harmful use of substance, no matter what the drug is. Some of you may have seen this picture before, but anytime we're talking about trying to wrap our hands around the harmful use of substances and addiction, the response has to be varied. We call it the continuum of care. So we have to do things on the left-hand side. We have to do health promotion, wellness promotion. We need to do prevention, and prevention does include education, but it also includes things at the micro level, like public policy, that can influence people not even starting to use. So we need to do promotion work, prevention work. Obviously, we need to do treatment work, and we need to support people in recovery. We can't focus on just one slice of the pie. We really have to have efforts that go across the continuum. We need to do that in our communities for sure, and Kim will probably speak of that, but we also need to mirror this continuum in the workplace. And doing prevention with adults is not too late. There are things we can educate adults about that really can prevent them from needing treatment or needing to be in recovery. Not Karen Pierce, not working partners, but the best strategy for addressing both prevention and responding is a comprehensive drug-free workplace program that is current. So 5 elements of a drug-free workplace that employers can put into place to prevent and respond. First of all, involves a policy and operations. We've got to educate our employees. Need to do supervisor training, testing in whatever dose is appropriate for the particular workforce, and finally assistance. Last year, Randy mentioned we were involved in a very large-scale project across the state for workplaces. We did a survey involving over 3,000 businesses. You might have taken the survey, but I've got a couple of survey results to show you in this next section. Number one is that 1 in 3 employers don't administer any of the 5 components of a drug-free workplace. So this truly is an antidote. This is something the workplace can do, but a lot of us still aren't doing that. I will put a plug in briefly for the Bureau of Workers' Compensation's drug-free safety program, in that if an employer will do those 5 components of a drug-free workplace, they may be eligible for a rebate on their workers' compensation and grant money to help them do the do, to help them write a policy, to help them do their education and training. Quite an opportunity. So let me just touch on each of these 5 things quickly. Policy plus operations. The policy needs to be written, needs to be customized for the organization, and it needs to be legally sound, of course. We need to have written operations so that the supervisor does know what to do if somebody presents them with information about a prescription. We need to have appropriate forms. It needs to be consistent with other practices and policies. Obviously, we need to have union blessing, and it does need to be state-specific. One of the things we know about drug-free workplace is that the states around all kinds of different drug issues can vary from state to state. The second component of a drug-free workplace is education, and I really believe that for current employees and their children, the workplace is a pretty amazing place to be able to do some real prevention education. Employees need to be given notice about the policy and sign off. It's not easy to pull employees off the job and teach them things, but doing that annually is important. It's got to be relevant because education really can motivate and it can prevent. When you take a look at just the opiate epidemic, when you consider that 4 out of 5 new heroin users started out misusing prescription painkillers, the workplace is a perfect opportunity to educate employers about safe and responsible medicine practices. We also know that kids of parents who talk to them about drugs are 50% more likely to use. I think, again, the workplace is a perfect opportunity to give tools to parents so that they can talk to their children. With supervisor training, it does need to be annual as well. Supervisors have a lot of power. They're the eyes and ears of the organization. But barriers do exist. They're uncomfortable confronting people. Sometimes their own use gets in the way of them being able to confront. So when we do training, we need to give them the skills. We need to support them. And most importantly, we need to give them procedures for how to respond. I know back in the old days when I was doing drug-free workplace supervisor training, a long time ago, true confession, I would run around to the workplace with my little suitcase of fake drugs, and I would hold up the suitcase and I would point out, here's what the different drugs look like, here's what the employee looks like if they're under the influence. But I gotta tell you, that's not the information supervisors need. They need to know what to do if they see it. And they need to be motivated to do that as well. Testing, a couple important things about testing. We need in our policies to talk about when we're going to test, how we're going to test, and most importantly, what we're going to test for. The survey that I talked about before, when you focus on the issue that the test, hang with me, this is a tongue twister, the test only tests what you tell it to test for. Employers need to know exactly what their drug tests are looking for. Now the survey result, the survey that we did said that only a third of businesses don't know what they're testing for. Take a look at this real quickly. In the old days, if you've heard of a 5-panel drug test, these are the only drugs that were picked up in the drug test. Amphetamines, which are UPS, cocaine, marijuana, PCP, and opiates. And opiates, in the purest sense of this word for this test, only meant organic opiates. Heroin, codeine, morphine. That's it. not testing for OxyContin, not testing for Vicodin, etc. Earlier this year, the Department of Transportation said that for Department of Transportation testing, they now had to include those expanded opiates, the hydros and the oxys. And a lot of other employers are testing for these additional drugs. There are a lot of our clients, even to date, that aren't testing for 6, 7, 8, and 9. They think they're testing for them, but they're not. So employers really need to pick up the phone, call your drug testing vendor, get a list of what you're testing for so you can adjust that if you need to. The fifth and final area of a drug-free workplace program is assistance. A lot of employers are spending time trying to figure out, do I terminate if somebody tests positive, or do I offer a second chance? And I will tell you, as the workforce availability changes, employers are more challenged with whether to terminate the person and look for somebody else or try to keep the employee. Ohio employers, if you take a look at best practice second chance, only about 30% of them are doing best practice, which means you test positive, you're off the job until two things happen. A counselor blesses you coming back and you test negative. Only about a third of employers are doing that, and another 27% terminating. I really believe, and we'll probably hear this word from every speaker, the stigma issue really influences employers' unwillingness sometimes to offer a second chance. We're still hearing people who are dealing with the disease as being junkies and druggies and stoners and entitled. And I really believe from a policy standpoint, that stigma keeps us sometimes from being willing to offer a second chance. Addiction, I think in this situation, not necessarily the drug is the primary issue. One more positive note before I stop. And we are in the land of opportunity right now. First of all, there are people coming together like never before. This type of diverse panel, this type of diverse audience would not have happened 5 years ago. I believe we are challenging the stigma. We're hearing it from the mouths of doctors and attorneys and treatment providers. I do think we are turning the tide and looking at this as the health issue that it is versus the moral issue. And we are starting to focus more on prevention, which I think really is an opportunity now. A couple of resources. Randy mentioned the Opioid Toolkit. It is a dandy resource. There is a course for employers. It's a computer-based course, 5 modules, walks you through what should be in a policy, how and when you should test, what different assistance options look like. And there's also a course for employees that is free on being a safe and critical consumer of prescription medications. I wish employers would make this mandatory education. Our website, we have a monthly e-blast with information that comes out every month. If anybody's interested in that or my slides, let me know and I can send those to you. And I think I'm out of time. Thank you.
Well, thank you, Karen. Again, another excellent presentation with some really profound results and research. It is encouraging to see that there is some good news to report. The efforts that we've taken in Ohio are working as it relates to opioid use. I think that the overdose deaths, though, have come from fentanyl and carfentanil and that kind of new wave coming in from China. But we are doing a good job. Things are working. And one thing that I wanted to underscore that Karen had said is that with related to prevention and a culture shift. We roundtable this at the Attorney General's office. We have looked at how the culture has shifted with regard to tobacco, with smoking, and how can we affect that same kind of cultural shift when it comes to substance use, drug use. And so we're looking at ways that we can impact the culture and with a diverse panel like this and getting the word out, and all of us that have previously been siloed working together to spread a message, having the physician community involved, the social service community, drug-free workplace, and certainly the business community. We see it at the Attorney General's office as one line of prevention. We are very passionate passionate about prevention and moving from K through 12 prevention education. We're working with colleges. More and more colleges and universities are putting in prevention programs, sober courses, sober classes and platforms. And the third component is the business community. The business community, our employees are captive audiences, and they can affect their family members by what they hear. And so it is absolutely crucial that businesses understand this and see the value in it and possibly sign up for the BWC rebate that we're going to hear about later with John Wilton's presentation on the panel. Our next speaker then on this fabulous lineup this morning is Kimberly Frazier. Kimberly Frazier is the Executive Director of the Lake County Alcohol, Drug, Addiction, and Mental Health Services Board, otherwise known as the Adams Board. Kim first joined the board in 1999 and held the position of Director of Quality Improvement before being named Executive Director in 2007. Prior to her move to the board, Kim held both clinical and management positions at the agency and the Adams Network. The mentor resident is an independently licensed behavioral health professional who did her master's and postmaster's work at John Carroll University. Kim is currently a state board member of the Mental Health and Addiction Advocacy Coalition and is past president of the Ohio Association of County Behavioral Health Authorities. Kim has run a very steady ship here locally, I know that personally, and is certainly a force for good in this area in Lake County, and I've had the privilege of working with her about 10 years ago now. Time flies. Kim, welcome to the podium.
Good morning, everybody. First of all, thank you for taking your morning to be here. It's the Wednesday before a holiday weekend. Holly Strano says it's going to be beautiful out, and you all have elected to spend your morning talking about opiates. We get that that is maybe not the most uplifting way to start your day, but this is a vitally important conversation. So thank you for taking the time. I'm here to talk a little bit about local resources. I will tell you first and foremost, if you're going to have an addiction disorder, Northeast Ohio is the place to be. We have some of the best treatment and prevention services available right here. So I'm going to talk a little bit about that. I've got some stats. I might blow through some of this quickly because it might be a bit repetitive. But to start with, if you're not familiar with us, Adams boards are the alcohol, drug addiction, and mental health services boards for the counties. We actually exist by state statute. The state of Ohio says that every county will have an Adams board, and essentially our job is to plan, fund, monitor, and evaluate the county's mental health and addiction recovery services. So we're sort of that behavioral health safety net. Our job is to make sure any person in our county, regardless of age, regardless of gender, regardless of their ability to pay, has access to the best mental health and addiction services when and where they want to receive those. And we actually deliver those through a network of agencies. So each Adams board contracts with a network of agencies throughout the county to be our provider of those services. We have existed for over 50 years. For 50 years, Adams boards have had this responsibility. As you can probably imagine, in the last couple of years, the majority of our time has been spent on this opiate epidemic, talking to, dealing with individuals, families who are impacted by opiates. And a lot of what we also do is go out and talk about this. I go out literally a couple of times a week and talk to businesses, talk to social service organizations, talk to schools about how this epidemic is impacting our community. One of the things I often do is I start with asking folks, completely voluntary, but how many people in the room know someone, a friend, a family member, a loved one whose life has been impacted by this opiate epidemic? Yeah, that's what happens. When I ask that, usually every hand goes up. Certainly when I think about this epidemic, I think about the clients that we serve. I think about the people who come through our doors at our agencies. I also think about my cousin, who about 10 years ago came back from Afghanistan with a horrific leg injury, on copious amounts of opiates. And now today, he doesn't get out of bed in the morning without popping his pills. He lives and breathes by his little white pills. He can't hold a job. He can't be a part of the family. This is his life. I also think about my niece who lives out in Sandusky, who was working a double shift one night at a restaurant and was tired and dragging, and a coworker said, "Hey, take this little pill. This will really pick you up." And now 3 years later, she's lost her job. She's lost her home. She's lost custody of her 3 children. And every single day, she takes a cab from Sandusky to downtown Cleveland to go to the methadone clinic, except for the days when she's scoring heroin on the streets. That's my reality. I am from a nice family, in a nice suburb, in a nice community, and that's my reality. And I think we have to frame the conversation like that, because this is not an us versus them disease. This is not an inner city problem. This is not a rural problem. This is a problem that's happening within the walls of your organization. And that's why we need to educate ourselves, and we need to educate our employees about what's available, about the reality of this, and about how to get help. So I'm going to talk very briefly about the scope of this problem. There's a reason that you can't open up a magazine or turn on the television or turn on the internet without hearing about opiates. The reach is unbelievable. Today, unintentional drug overdose death is the leading cause of accidental death in Ohio. More people are dying from drug overdoses than from car accidents. And in fact, we heard earlier, 14 people are going to die today in Ohio from drug overdoses. 14 people. I've been talking about this endlessly. In the last 9 months, I've had to update this slide twice. 9 months ago, that number was 8. 5 months ago, that number was 11. Today, it's 14. And we are going the wrong direction. We know that 1 in 5 teens say they know someone who's abusing prescription drugs. And that number is probably much higher. That means my 14-year-old daughter, who graduates from 8th grade tomorrow, probably knows somebody, a classmate, who's playing around with prescriptions. And we also know that alcohol and drug abuse is among the top 3 leading causes of death for our 16 to 24-year-olds. So it is hitting our young people. But make no mistake, this is hitting every single demographic. We know that substance abuse affects 700,000 children in Ohio. Of those, nearly 14,000 of them end up in the custody of Children's Services due to parental drug abuse. That means this morning, when your alarm went off and you woke up in your bed and you thought about, what do I have to do today? And you climbed out of your bed, 14,000 children in our state woke up, opened their eyes, and didn't see mom and dad. Maybe they saw grandma, maybe they saw an aunt, maybe they saw a stranger because of this epidemic. In Lake County alone, we have 89 children in the custody of Children's Services. And we have more than 1,000 grandparents raising their grandchildren. That means that your employees may be waking up in the morning and struggling between, do I go to work or do I get my grandchild to their doctor's appointment, because this is now my responsibility. We also know that overdose deaths are rising. In Lake County alone, we had 42 deaths in 2015. That more than doubled in 2016. We don't have the final numbers for 2017, but we know that it's higher still. You've heard that twice already. We're going the wrong direction. Some projections say that with the trajectory that we are on, if nothing changes, this epidemic will not burn out. And by burn out, they mean kind of level off to where death rates were in the mid-'80s until 2032. How many more lives are going to be lost if we don't do something to intervene? We know that stigma is an enormous barrier. 1 in 10 people in the United States has a substance use disorder, but of those, only 10% will actually receive treatment. 10%. That means 9 out of 10 people dealing with this disease are going it alone. They're not talking to their employer, they're not talking to their family member, they're not getting connected with treatment. We know that addiction and abuse are not age specific, nor are they gender specific. Here in Lake County, in our nice, wealthy, suburban county, nearly every single city and township has lost somebody to an overdose. Last year in Lake County, we lost a 14-year-old and we lost an 89-year-old and everything in between. And we know that fentanyl is increasing dramatically. We're talking about opiates, but truly, this is a moving target for us. And make no mistake, the individuals who died from overdoses where fentanyl was involved did not know they were taking fentanyl. They did not know that was laced in with what they were taking. So let's talk about workplace impacts. We know this number is now higher, but estimated that American employees lose over $80 billion a year in productivity, absenteeism, accidents, healthcare costs because of addiction. That means every single employer in our state and in our country probably has their bottom line impacted because of this epidemic. We know that 2/3 of those using prescription meds say so they're doing so while on the company payroll. Healthcare costs are 3 times higher for employees who are abusing or addicted. 9.1% of full-time employees acknowledge that they're illicit drug users. 13.7% of our part-time employees. And of those who admit to using drugs illegally, 44% walked into your shop and sold those drugs to a coworker. 64% said, yeah, this is impacting how I do my job. 18% stole from their coworkers to support their habit. This impact on your bottom line is coming from every direction. The good news is that there are resources available. We are responding locally. In 2010, we started the Lake County Opiate Task Force. We pulled together partners from social services, healthcare, the coroner's office, law enforcement, criminal justice, to talk about how we could collectively begin to impact this epidemic. We had 2 major areas of focus in our county. The first was on prescription drug disposal, and the second was on public education. If you live in Lake County, you should know that there are 7 permanent drug drop boxes throughout our county. I'm actually very proud to say we were, I believe, the first county in the state to establish permanent drug drop boxes. So you can walk into a local police department and you'll see something that looks like kind of a green or gray mailbox. You can anonymously dispose of any medication. It's time for us all to clean out our medicine cabinets. We've got to get these drugs out of our medicine cabinets and out of the hands of our kids or our neighbors or the guy who comes to fix the sink. We've got to dispose of these. To date, here in Lake County alone, we've disposed of 31,000 pounds of unused or expired medications. That's 31,000 pounds of pills that are not in the hands of our kids. And that's a resource that's available for your employees. The other thing that we focused on was public education. We know that our very best defense against this epidemic is conversations. It's talking about it. It's lifting the veil off of this and being willing to talk about how it can impact our kids, our adults, our senior citizens. So we create literature. You'll see on the table out there that tons of literature. We'll make it available to any business, anyone throughout the county. We know the more we talk about it, the better our chances at combating this. This is our newest initiative, and this is a resource that is available for employers throughout our county. This is a partnership between the Lake County Adams Board, our Opiate Task Force, and Leadership Lake County. I mentioned we've been going out and talking to anybody who will listen. I will tell you, the hardest nut to crack has been the business community, getting folks to let us in their doors to talk to their employees. So back in the fall, we partnered with Leadership Lake County, which has the leaders in the business community, and we said, help us open doors. Help us get into businesses, small businesses, large businesses, anybody, to talk about what's the reality of this, to talk about what services are available. And they agreed to partner with us, and I will tell you that the response has been unbelievable. To date, we've done over 100 presentations. We've reached over 3,000 employees in this county. And It's very simple. We come into your business and we do an hour-long presentation, completely free. We talk about the nature of addiction, the fact that this is a disease. This is not human weakness. This is not a character flaw. This is not a failure to pull yourself up by your bootstraps. This is a disease like heart disease, like diabetes, like asthma, and it's also a treatable disease. We talk about warning signs, red flags. We talk about things like Skittles parties. If you don't know what a Skittles party is when a group of teens get together and they know that they can't get any beer and they know they can't score any pot. So they all go home and go to their parents' medicine cabinet. And they pinch some pills out of a prescription bottle because our kids know if a doctor prescribed it, it must be safe, right? And they take them to a party and they put them in the bowl. And the game is, you take a red and a blue, and you take a green and a yellow, and I'll take a pink and a white, and we're just going to see what happens. And this is how our kids are playing around with drugs. And this is not urban myth. This is not a legend. This is happening. And if your employees know about this, then they know to have their guard up. They know to be watching for things like Skittles parties or farm parties. But that's what we do. We educate your employees about what those warning signs are. We talk about ways to fight back, the importance of purging those medicine cabinets. We talk about treatment options. We know that sometimes an employee doesn't want to go to their boss and say, hey, I think I have a problem, I need treatment. And there are ways that individuals can get connected with treatment, free of charge, and anonymously. We want to make every door open when somebody's ready to get help. We talk about resources and how to access them. These presentations are available to any business in our community. So I mentioned we've done over 100 presentations. I have discovered Lake County in the last 6 months. I have gone into manufacturing companies that I've only driven by on Tyler Boulevard. I've gone into hairdressers. We've talked to small businesses, large businesses, anybody who will listen. If it's something that sounds like it would be a benefit to your business, give us a call. We will come out and talk to anyone. And we'll talk to any shift. We've gone out and done talks at 5 o'clock in the morning to catch the tail end of the overnight shift. But this is a tremendous opportunity for you to help educate your employees without you having to be the one saying, hey, do you want to talk about drugs? That's a tough conversation to have. If we come in, it's amazing how people are suddenly willing and able to open up to those conversations. I want to mention briefly that recovery and treatment options are available here in Lake County. We have in our county one of the best and richest arrays of behavioral health services anywhere in the state. Folks in Columbus look to us to say what kind of treatment is working. So I'm not going to go into great detail, but I will tell you that we are continually exploring new treatment options. One of the challenges that we're facing in this epidemic is that there is no silver bullet. If we knew exactly what kind of treatment worked for everybody, we would be doing it. Unfortunately, there is no miracle. There is no silver bullet. So we try new things. We explore new opportunities. We create new programs. Our services are available to anybody. Again, regardless of their ability to pay. We have programming available for children, adolescents, adults, senior citizens. A couple that I want to touch on very briefly. The first is our opiate recovery transition program. So 5 years ago, if you had an opiate addiction and you felt like you really needed help in getting off your opiates and you went to the emergency department and you said, I need to be in a hospital, nobody would pay for it. Private insurance wouldn't pay for it. Medicaid wouldn't pay for it. The local system wouldn't pay for it. Why? Because the physicians would tell you that it's not a medically dangerous detox. You can detox at home. We know that doesn't work. So today, insurances more and more are willing to pay for some level of detox. We've also invested locally. We know that even if insurance pays for that 2 or 3 days of inpatient detox, a person is at their most vulnerable if they go through 3 days of inpatient detox and walk out of the hospital, because on day 4, they're still going to be craving and they're going to overdose. That's when people are dying. So we created this program. If a Lake County resident comes into one of our emergency departments, Lake West or Tri Point, and they are ready and seeking treatment for opiates. We can get them into a 7 to 10 day inpatient stay at Windsor Laurelwood Hospital. During that time, our outpatient providers are going in and talking to them, getting to know them, talking about what recovery can look like. On that last day in the hospital, they receive a Vivitrol injection. Vivitrol is a medication-assisted treatment. It is an opiate blocker. So if I get a Vivitrol injection for the next 30 days, if I take opiates, I won't get high. It will have no impact. This is not a replacement for the drug. This buys us some time. It gives us that time to help get somebody involved in treatment, get them recognizing what recovery can look like. So they get that injection, and then we literally put them in our car and drive them to outpatient treatment, whether it's residential treatment or intensive outpatient. We want this to be seamless. We know that there are so many opportunities for somebody with a substance use disorder to fall through the cracks when they're trying to get help. So this is our program to help people seamlessly get into treatment. We also offer residential treatment in our county, and we're expanding that opportunity here in the county. We're beginning to offer recovery housing. We know when somebody is done with their residential treatment, done with their treatment regimen, sometimes they just need a safe place to live. And we get them there. We also have aftercare services and supports for the family. Supports for the family even when that person with the addiction is not ready for treatment, because we know that families struggle with this. I want to mention one more thing about treatment. With epidemic often comes opportunists. And what we are seeing in Ohio and throughout the country is opportunists, people looking to capitalize on this epidemic. Have you heard of the person coming into your church group and saying, you know what, I know your loved one is struggling, and I got to tell you, there's no good treatment here in Lake County, but if you have insurance, I will personally buy you a plane ticket and get you to a treatment facility in Florida. State of the art, best treatment you can get. And those are scams. People are falling for this. They're sending their loved ones down to Florida to go to treatment facilities that don't really provide any treatment. Simply milk the Medicaid for all, and then leave people to die on the streets. We're losing Lake County residents on the streets of Florida because of this. And this is happening pervasively. They're targeting our state, and they're shipping people out of state, and they're making money off of this epidemic. We also see things like when you see the billboards for things like the Addiction Treatment Center, cash and carry Suboxone clinics. You walk in with $250 and you'll get a script for Suboxone, and your treatment is, don't do drugs, come back in a month. There are opportunists at every corner. So it is so important for us as individuals and as employers to check out and make sure that the treatment that's being offered is legitimate. And I'm going to give you a great shortcut to that. Before I do, let me talk very quickly about our latest program, which is our quick response team. We know that every single day in our county, folks are calling 911 because somebody's overdosing, right? And so the emergency squad goes out and they administer Narcan. If you don't know what that is, it's you shove it up somebody's nose, it immediately reverses the overdose. They put them on the squad, they take them to the emergency department, and despite the fact that we have psychiatric social workers 24 hours a day, 7 days a week in both of our emergency departments, 99 times out of 100, that person gets to the ED, gets up off the gurney, and runs out the back door because they're scared, because they're in shock, because they don't know what's going on, they're afraid they're going to get in trouble. We're just not able to connect people with treatment at that point. So our quick response team, which is a partnership between our Lake County Sheriff's Office Detectives Bureau, our behavioral health system, and our firefighters and first responders in the county, go out as a team, ideally 3 to 5 days after that individual overdoses. A sheriff's detective, a behavioral health professional, and a first responder, in plain clothes, in an unmarked car, go to that person's house. They knock on the door, and they don't say, you just broke the law. They don't say, we want to search your house. They say, you almost died, and we might not get here in time the next time. Please let us help you. And they talk to that person about treatment. And if the person's willing, they put them in the car and take them directly to treatment. If the person's not home, they'll talk to their family members. They'll talk about what's available in our county. We've just piloted this program. To date, we've done about 100 runs. About 50% of the time, people are receptive, and that's a huge success number when it comes to this epidemic. So that's one more resource available to us. I mentioned the shortcut. In Lake County, we have our Lake County Compass Line. This is sort of the 211 for behavioral health. It's Monday through Friday, 8 to 4:30. It's housed right in our Adams Board office. A call to the Compass Line gets you connected to a triage specialist. If you have an employee who you think needs help, and you call the Compass Line, and it's completely anonymous, she's not going to say, oh, okay, call Signature, call Lake Geogga Recovery Centers. She's going to help you navigate the system. She's going to talk about what kind of insurance does the person have? Where do they live? Do they have access to transportation? Is this an individual problem or a family problem? We have a massive database that has every single provider, not just Adams-funded providers, but every provider in Lake County, where they are, what their hours are, when they have open appointments. She helps you navigate the system. She can even set up three-way calls to get somebody immediately linked to services. So that's a resource that's available to any one of your employees in Lake County, to any one of you, to your family members. A call to the Compass Line is your very best way to get connected with treatment and resources. It is also the way to access Operation Resolve. If you want us to come in to your business and do presentations, call the Compass Line and ask for Operation Resolve. That is an enormous amount of information in 25 minutes, isn't it? We are your resource. Our job is to be here for any Lake County resident, any business, and again, there are Adams boards in every single county in this state. So we should be your point of entry. And a word about those opportunists: if you hear about something and it sounds too good to be true, call our Compass Line. We'll let you know if they're licensed, if they're certified, if they're legitimate, or if they're scamming you. And with that, thank you very much for your attention.
Thank you, Kim. I think that the speakers just keep outdoing themselves as we're going along on the panel. For those of you who haven't met Kim Frazier or had interactions with her, I'm sure that she's convinced you that what I said in the introduction of her, that she is a force for good in Lake County. She certainly is. And while I've done more work, much more in the law than I have in policy, I can tell you that the work that Kim Frazier is doing with the Adams Board in breaking barriers in the business community is unprecedented. And so thank you. And on behalf of Attorney General Mike DeWine, thank you so much. And we would like to highlight your work statewide and possibly make it a pilot. I did not know that you were doing that here in Lake County. And so thank you. That work is needed, and it's really breakthrough work. So thank you. I have the privilege next to introducing Attorney Grant Keating. I see that in my former life of being a prosecutor not only in Lake County, and I see some former Lake County prosecuting attorney colleagues and law school colleagues, also Carol Shockley from the Cuyahoga County Prosecutor's Office of work many, many years ago. I have the privilege of introducing to you Grant Keating, also formerly of the Lake County Prosecutor's Office. But Grant currently works at Dworkin and Bernstein, a Great Lake County firm. And Grant works in the Business Law and Commercial Litigation Group at Dworkin and Bernstein, where his practice has addressed issues from e-commerce to professional negligence. He has been recognized as a Super Lawyer Rising Star 6 times in the last 8 years, which is no surprise to me because he was one of my law clerks at the Lake County Prosecutor's Office and certainly a rising star there as well. Grant's practice now focuses on business law and commercial litigation. During his career, he has successfully represented a wide variety of business clients at trials, appeals, and alternate dispute resolutions. And Grant is going to speak to the employer-employee liability issues in the substance abuse arena. So, Grant?
Good morning, everyone. Thank you for being here. I'm filling in for Rick Selby today and Kristen Kraus, who lead our employment practice group. Regrettably, they're in trial today. They would have liked to be here to talk about this. But obviously, from the speakers who've spoken so eloquently before me, we're dealing with a very challenging issue for employers. And the thrust of my presentation is to try to help employers make sure they're in compliance with employment laws as they deal with this great challenge. So one of the laws I want to talk about is the Americans with Disabilities Act. How many people are here with companies that have more than 15 employees? Okay, if you have more than 15 employees, the ADA is going to apply to you. So the act was enacted to prevent folks from disabilities from being discriminated at the workplace, in the community. So the starting point with any analysis under the act is whether or not the condition is a disability. Disability is defined as anything that substantially interferes with a major life activity. Major life activities can be as simple as things like eating, breathing, walking, and get as complex as ideas like working or being able to concentrate. I think that we can all take from the prior presentations that opioid use and substance abuse addiction problems is probably going to fall into what is classified as a disability under the Act. Now, there is one exception, and that's for employees that are currently using an illegal drug. When the Act was enacted, the legislators put that in there to allow employers to take adverse employment action against anybody who is currently using an illegal drug. So what's current? Current is kind of a complex analysis, and all of this is fact-based and has to be analyzed on an individual basis. But they kind of say you know it when you see it. One thing is for sure, one of the cases I read dealt with a nurse who had been stealing prescription drugs, who was later terminated, who said that the termination was in violation of the ADA because she had a substance abuse problem. In that case, the court said, no, you fall under even though that she was clean, at the time that she was terminated for the reason that she was taking the drugs at the time. And the judge said that employers don't need to catch their employees with a syringe in their arm or their mouth on a bong to determine whether or not they're currently using the drug. So one surefire way to determine whether someone is currently using the drug is if they test positive on a drug test. The analysis changes if it's a former use of drug or former drug addiction. The ADA is going to protect people that have been rehabilitated or completed a rehabilitation program so long as they're not currently using drugs. So you can't take any adverse employment action against those people if they're not currently using and they've been rehabilitated. With opioids, there's also an additional issue is whether or not the drug use is legal versus illegal. Obviously, a number of these people are taking these drugs as prescriptions in accordance with the directions that they were prescribed from their doctor. If that is the case, that's the lawful taking of the drug. If they're using the drugs outside of the directions that they were prescribed in, that's going to be determined to be unlawful use. And in addition, if they're taking any street drugs or anything that's on the National Controlled Substances Act, that's also going to be illegal, and they're not going to get any protection under the ADA for that. So when you're dealing with employees that are taking drugs that are being prescribed by their doctors, even if there are effects from those drugs that are having an adverse effect on their performance of their job duties, they're still going to be covered by the ADA. So anytime there's a disability and it's affecting the essential functions of their job, you have to engage in an interactive analysis with your employee to determine whether or not a reasonable accommodation can be made to allow those persons to continue to work. A reasonable accommodation is anything that's not going to cause undue hardship on the business. So an example that I can think of is if someone has surgery and they're taking painkillers, and because of their painkillers are not able to get from their home to the office, one potential reasonable accommodation would be to allow them to work from home, or potentially have a different start time, or allow them to take additional breaks during the day. If you can have that reasonable accommodation, you can't take adverse employment action against them just based on their use of lawfully taking prescription drugs. There is an exception to that, and that is even if they're lawfully taking the prescription drugs, if they pose a substantial risk to the health or safety of other people in the workplace, that direct threat exception will allow you to take adverse employment action against them if a reasonable accommodation can't be met. So when you're doing that analysis, it's important to focus on what is this person actually doing for me and what is their job description. So for instance, your bookkeeper, he might have the possibility of stapling his hand if he's under the influence of prescription drugs, but that's not a substantial threat to the health and safety of your other employees, as opposed to someone that is operating the forklift in the warehouse or utilizing a commercial driver's license. So depending, again, you're going to want to do a fact-based analysis, get your employment lawyer on the phone when you're making that determination. But if they are a direct threat, you can take the adverse employment action against them. Another statute that I want to address is the Family Medical Leave Act. The Family Medical Leave Act is going to affect those of us that employ more than 50 employees within a 75-mile radius with each other. So, for instance, Dworkin and Bernstein has 2 offices, one in Paynesville, one in Cleveland. Our total employees total more than 75 at both locations, and because of that, we are governed under the Family Medical Leave Act. So take that into account. A lot of people get confused. They think, well, I only have an office that has 35 people, but their satellite or other offices around them get that number over 75, so they don't realize that the act applies to them when it actually does. So eligible employees under the act are employees that have worked at the business for over a year and have worked for 1,250 hours for the employer during that year. And if they're eligible, they're entitled to 12 weeks of leave to deal with serious medical conditions affecting them or serious medical conditions affecting a family member that they need the care for. Advance notice should be given when requesting leave, but it's not necessary that you do if it's a medical emergency. You also, this is a point of confusion with many employers. When an employee comes to you to take leave, they don't need to say, I'm requesting leave under the Family Medical Leave Act in order to be covered under it. If they come to you and they ask for leave, you need to instruct them to comply with the requirements that are hopefully included in your employee handbook that deal with what needs to be done to get leave approved. And an employer has the right to obtain medical certification, a doctor's note that is justifying the leave before they allow it. And again, if it's a medical emergency and it can't be provided in advance, the determination is whether it was provided in a reasonable basis. So substance abuse is generally going to be considered to be a serious medical condition that you can request leave for, whether it's you that is seeking treatment or one of your family members that you need the care for. There is one exception, though. In order to get leave under the Act, the substance abuse treatment needs to be administered by a healthcare professional. So if you have an employee come in and they indicate to you that they have a problem with heroin or opioids or generally, and they just need to clear their head and take a couple weeks off, that's not going to be sufficient to cover them under the FMLA. Now, of course, these are the minimum requirements of what I'm talking about. If you want to give them the leave, that's well within your rights to do so. But in order for them to be eligible for the leave and the protections of FMLA, that treatment needs to be something that's prescribed by a doctor or healthcare professional, or a referral out to a healthcare professional. Again, another thing that I want to talk about, and this goes with the ADA and FMLA, whether it's a disability or a serious medical condition, those are going to be protected under those acts, whereas employee misconduct will not necessarily be protected by those acts. So I was talking to someone earlier today who indicated that one of her employees was absent from work quite a bit, and she ended up having to let that employee go because of violation of their progressive policy of discipline, which is fine. You're entitled to do that. And she later found out it was because this person was addicted to opiates. The mere fact that someone is addicted to opiates isn't going to give them preferential treatment under your corporate policies. So if you're having problems with employees, especially with absenteeism, that's where it shows up a lot, you can take that discipline against them in accordance with your policies that you would with any other employee. There isn't a safe harbor for people who are suffering from these issues. Now, again, you may not want to do that. I know a lot of us here are especially receptive to trying to help our employees, but your lawyer's concern is going to be keeping you in compliance with the law. And I think it's important, if you are going to give a reason for termination or suspension, that you make sure when you're giving that reason, it's related to the actual misconduct, and make sure you're not addressing it towards a disability or an addiction issue, because that could be held against you in a later legal proceeding. I think, as these issues come up, they can be murky areas, and especially if you find yourself in a courthouse one day litigating them, there's going to be two sides of the story. Obviously the employee that's been affected by this is going to, present the case. No, they took this action against me because, I'm a recovering addict. As opposed to the employer is going to say, no, we actually took this because you've missed 6 days of work. So whether or not there's a reasonable suspicion, you got to be careful in what you do, and you want to have that interactive analysis with your employee to determine what are the causes of these problems, to make sure that you have everything documented right and that you're acting within your own corporate policies and taking your disciplinary action. Mr. Condon?
Grant, you mentioned first that if someone has an active drug problem, illicit drugs, you can let them go.
Well,
Those are illicit drugs.
That's a really good question, and this is something that comes up a lot. Maybe I'm hanging around the wrong people, but every once in a while I'll be at a cocktail party and someone will say, well, if I ever had a problem, I missed a week of work because I was on a bender or something, I just go to my boss, and before they fire me, I'm going to tell them I'm an alcoholic. And then if they try to fire me, then I'm going to be covered under the ADA or the FMLA. That's not the case. Again, there's a big difference between the misconduct and the disability, and how that's going to be treated under the law. So again, if you are being disciplined for anything that's in violation of your corporate policy, that's going to be appropriate. And you can't go after the fact and say, well, I know I missed a week of work, but it's because I'm a heroin addict. You're not going to be able to fall into it. So the misconduct is different.
Yeah, so I'm having a hard time envisioning the situation when someone could come in and say, I need FMLA, I'm a heroin addict, but that was a year ago and I'm recovered, then why do you need it?
So the FMLA is for treatment. So you can use it for treatment-based leave. Now, there's a lot of people, I think most of the people in this room understand that recovery is an ongoing process, and people are going to have relapses. One of the issues is whether or not you have a drug-free workplace policy. There are some employers that have a policy that just say substance abuse is not allowed. It's perfectly legal to have that policy. And if there's a violation of that policy, whether or not you found out about it because someone was taking leave, you can take adverse employment action against them for violating that policy. But you can't take adverse employment action in response to someone requesting the leave. So it is a very complicated issue. Again, as it arises, my recommendation is for you to get on the phone and talk to your employment lawyer to deal with that issue, to make sure that you're following the proper steps and dealing with your employees' issues the way that they need to be dealt with. One other thing that I wanted to talk about before we get into our panel discussion is drug testing. The state of Ohio doesn't really have any specific laws as to when you can test, so mostly you're going to be restricted by the guidance under the ADA. And the ADA is a little bit more restrictive as to when you can make medical inquiries of your employees. They deal it with 3 different stages of employment. There's the pre-offer stage, when you're just taking applications, the post-offer stage, when you found a candidate and you're going to offer them a job conditioned upon some sort of testing, and then there's testing during employment. During the pre-offer stage, no inquiry, you cannot make any inquiries as to whether or not someone is disabled. No disability questions. You can't ask anybody about what prescription drugs they're taking, or else you can be in violation of the ADA. But again, illegal drugs are specifically excluded. So if you want to ask any candidates whether or not they're taking illegal drugs, and they answer yes, there's probably a lot of reasons why you don't want to hire them. But if they do answer yes, that's completely appropriate. And you can also do drug screening for illegal drugs at that time. And if it comes up on the test that it's illegal drugs, you can decline to offer any employment to that person. Obviously, this gets a little bit complicated, and this sort of builds on what Karen was talking about, is when you're dealing with opioids, if you don't know what you're testing for, it could be very difficult to differentiate between street drugs and prescription drugs. So again, you have to be very careful that you're testing for illegal drugs if you're doing it in pre-employment testing. After you've made an offer, there's a lot more flexibility about what you can ask. You can have people do medical exams. You can have people test for illegal drugs or lawfully prescribed drugs. But that testing needs to be consistent with the job that you're offering, and it needs to be applied consistently to everyone that is seeking that category of jobs. Post-employment, one thing that you can do is put in your company policy or your employee handbook that you're allowed to do drug testing at any time. And if you put that in your handbook, that's going to be enforceable. If you don't have something like that in your handbook, you can. There's 2 different sort of tests or analysis that an employer can use as to when they test their employees for drugs. The EEOC, the Equal Employment Opportunity Commission, has a test where employers are allowed to test their employees if there's any sort of objective evidence that the test needs to occur. So again, if an employee is not showing up to work and excessive absenteeism, you can implement the test. There's a different standard that's a little bit broader that's been presented by a number of courts that dealt with the issue, that if an employer has any articulable basis for testing an employee, that's sufficient to pull that employee out and test them. So if you see an employee falling asleep at work, or if there were an accident, or any other number of reasons, as long as you can articulate a basis for testing that employee, that's going to be okay under the ADA. I know that there's been some discussion about the Bureau of Workers' Compensation drug-free workplace safety program. That is not a mandatory program, but it provides an incentive to employers to insist that their workforce is drug-free. If that's implemented, there are certain times where you must test. I think there's mandatory testing, pre-employment under that plan, and you need to engage in testing after any accident to ensure that you have that, to get that discount, to be eligible for the discount. And additionally, under the BWC, if an employee has an accident at work and you do testing and they show up positive for illegal drug use, they're not going to be entitled to any workers' compensation benefits at that time, too. So that's just a little blurb on testing in the workplace, and that's all the material I have. Again, I want to tell you guys again, what we're talking about here is compliance with the employment laws. These are minimum compliance. So if you want to offer your employees a second chance and help them work through some of these problems, you are well within your rights to do that. And I think I would agree with the other panelists that that's probably the best practice approach as this issue gets more complicated as we go on. Thank you.
Thank you so much, Grant, for giving us that overview. It is an exceptionally complex legal set of issues that really requires counsel in these areas. But it is interesting to see that there are so many more people, more professionals advocating for second chance agreements when we would not have seen that even just about 2 years ago. So thank you, Grant. Our next speaker, she is last for speaking, but certainly not least, is my dear friend and tremendous colleague, Kim Leininger. Kim is a community builder. She certainly does that and has done that for many decades, who utilizes partnerships and collaborations to address local needs and issues faced by Geauga County residents. Kim is a strong believer in social justice and strives for positive community change really on a daily basis. As the executive director of the United Way Services of Geauga County since 2003, Kim has been able to leverage relationships with community leaders and professionals to really redefine a vision for United Way that is innovative and forward-thinking. Prior to her tenure at United Way, she served as the executive director of Women's Safe, a domestic violence shelter and resource center, and as a hospital social worker. Kim is as an active member of the Geauga Family First Council. She is vice chair, Leadership Geauga Board of Directors, the youth program chair, and she serves on the University Hospitals Geauga Medical Center Board of Directors and a number of other boards as well. I had the privilege of working with Kim for a few years in the aftermath of the Chardon High School shootings with the Crime Victims Services section of the Attorney General's office. She not only worked to steady that ship as the community was torn apart as a result of the Chardon shootings. It was a very tumultuous and gut-wrenching time. She led the Chardon Healing Fund, led services to the families, and really was a key in helping the community recover and was looked to on a national level. And so it is really my privilege to introduce our next speaker, Kim Leininger. She's going to say a few words on behalf of her work and in Geauga County. Thank you.
So I'm not going to talk about United Way specifically, but just a quick touch point on that. You know, in Geauga County, we really are researching and learning and understanding what the needs are, trying to pull together collaborative and diverse partners that develop strategies to help individuals and families towards self-sufficiency. So that's our focus in Geauga County, where Kim mentioned they're really looking at mental health. We're really looking at self-sufficiency and what are those barriers that exist for individuals and families in the community. I did grow up, I was born and raised in Lake County, and I am a graduate of Riverside. But how many of you are from Geauga County? Yeah, I didn't think there were many of us in the room, but okay, that's okay, because 211, I'm going to, as I talk a little bit about this signature program that we operate through our United Way, it will give you an idea of how you're going to be able to connect your employees and their families to services. So the example was given already about an employee who maybe is raising their grandchildren and running into issues and barriers along the way. And 211 is a service that can help with that. Hopefully you've all heard of 211. I did leave brochures, posters, some pencils and pens out at the table, so please grab them when you walk out. But 211 really is a three-digit number, very easy to remember. Just as you would dial 811 before you dig in your yard, you're going to dial 211 when you need access and navigation with Health and Human Services. The services in the Health and Human Service field are very complicated. As you heard, evidence-based programs. Well, what does that mean? Hours are different. Things are changing every day and very quickly as to what's available in the community. 211 is really the experts at understanding what is available in the community and how to navigate people through those services. About 93 to 94% of our country is covered by a 211 service area. I will tell you the part of Ohio that is not is our southeast corridor that really lacks the 211 infrastructure. This chart, I know it's hard to see, but the darker areas show you areas where 211 is at 100% coverage, down to the gray areas where there's less than 20% coverage with a 211. And I'm going to go kind of fast because I really wanted to show you this video, which gives you just a peek into the navigation services that happen with 211.
211 is a service where people can call 24 hours a day, 7 days a week, with almost any concern or need that they have. And we will try to find resources out there in the community that can help them. There really isn't anyone else out there who does what we do. We have some researchers that do an amazing job of keeping connected with all of the resources that are out there, keeping it up to date.
It would be very detrimental to people who would spend their last dime on, a bus trip somewhere when something is closed or they don't qualify for the service. So we put a lot of effort into the quality of that database.
2 years ago, I was at Tri-Cities Upward Bound program, and a gentleman raised his hand. I said, "Oh, do you have a question?" And he goes, "This man saved my life." He had called on January 20th. He had lost his job. He had been in a domestic dispute with his significant other, and she had kicked him out of the house. He spent the night in a door frame. It was about -9 that night. The buses in Cuyahoga County were free that day. I told him to get on a bus and go to 7000 Euclid Avenue, where the VA has their homeless drop-in center. I told him, you need to get back into school to see if you can get a better job. 2 days before he graduated from Tri-Cities Upward Bound, he got a new job. On July 1st, he moved back into his own apartment.
211 informs the community and United Way about what people need, where there are gaps, where there's unmet needs. That information can then be used to make funding decisions and to help bring people together. And United Way is perfectly positioned to convene and to fund.
I was talking to a young lady one day, and she had initially called and said that she was looking for help with furniture. And I said, okay, well, I can help you with that. And I gave her some information on how to access some help with furniture. But then, I asked that next question, well, what's going on? So she said to me that over the weekend that her husband was arrested for domestic violence. He had been abusing her for many years. This was the last straw, and she needed to get out. And so she found a place, and she scraped up every last penny that she had for first month's rent and deposit for a new place for her and her child. You know, after we're having this conversation, she started to really open up. And she told me, the reason that I stay with him is because I have diabetes and I'm insulin dependent. And even though I work, I can't get health insurance through my job. And my insurance is, you know, I'm on his insurance. So the only way that I can access medication and health care is by staying married to him and using his insurance. And so I asked her a few more questions about, what her income was. And as it turned out, she was eligible for Medicaid, and she had no idea. So I gave her information on how to access that, and she started to cry and said, you just took away the only reason that I had to stay. And now I know that I can manage on my own. It moves me to know that I was able to help change this woman's life and get her in a safe place, that she was able to make that change after feeling trapped for so many years.
When somebody calls you up uncontrollably sobbing, and by the end of the call they have a plan, that makes such a difference.
And now that I do this, and my dad was a vet, he would be proud of what I'm doing.
So I thought that was a really important video to show because it shows the navigation services. We in Geauga, I could see the writing on the wall. It's a very expensive service to maintain, very expensive because of, number one, the technology that has to go behind it, the telephone systems that are required, and the database upkeep. In 2007, I went to United Way of Greater Cleveland and said, how could we partner our 211s? So we did that, and now there are 26 counties in the state of Ohio that also partner with United Way of Greater Cleveland. So we have a shared infrastructure. They hire people locally in local communities, so they cover Toledo, but people are based in Toledo providing that service. So we were able to really save and cut down on some infrastructure costs. Basically, I think this is really important. It's the complexity of social needs. So somebody in your workforce is dealing with an opiate issue. There are probably a lot of other things happening in their lives. So the example you saw, the woman called about a furniture need, but it led to a conversation as they dug a little bit deeper into domestic violence, the issue of the diabetes and why she was in this relationship and staying in this relationship, to the opportunity for her to take a step towards self-sufficiency. Getting onto Medicaid, she was working. It wasn't that she wasn't working. She's working, but she qualified for Medicaid, and that allowed her the opportunity to begin to make a different plan for her life than she would have had otherwise. Just really quickly on the database, there are over 4,000 social service agencies in the database. When I talk to social workers and they say, I know where to send people, I laugh because there is absolutely no way somebody knows what every service those 4,000 agencies are providing, because they have over 24,000 programs. So in Geauga, our hunger task force pantries are linked through 211. So the pantries, if they have to close, many of them are in churches. If they have to close because of a funeral that day, they call 211 and let 211 know we are not providing services today. So if you don't call 211, you're going to go to that pantry thinking you're going to get food, and you will not be served. So 211, it's really, really important. Annually, they make over 100,000 updates to the database. The database is updated annually. As you heard a little bit, every agency is contacted, and they go over every element that we have listed in that database, and they have the opportunity to update that. There's also interim updates when our staff are out at meetings, or sometimes a client will call back and say, you know what, that didn't work. That service wasn't available anymore. Or agencies will call as they change things. Very much like libraries use the Dewey Decimal System. I know most of us will remember that. Or in the healthcare field, the ICD-9 codes, the disease classification codes. We use taxonomy codes for health and human services as well. This allows us to not only look at and pull data based on what needs we were able to meet, but also what needs in the community go unmet, which is really important as we're really trying to plan and strategize services in the community. This just gives you a quick sample entry. There's a definition for every service and also terms in which and ways that those services can be looked up. Nationwide, there's about 13 million calls to 211s across the country. The number one need is housing and utility assistance, but the second need, 2 million calls a year around health and mental health services and needs. We know in Geauga County, and this is the exact same list, at least number one, and the others are in a little bit different order for Lake County, but food pantries. Number one need in both Lake and Geauga counties. Our unmet need, in Geauga we do not have a homeless shelter. But quite ironically, Lake County does, and it's also the number one unmet need in Lake County is a homeless shelter. About 47% of the individuals who call 211 in Geauga are 49 years of age or younger. That 50 and over population is about 57%. I'm sorry, it was 43 and 57. What's interesting, and I think from a workforce standpoint, is being able to take care of your employees now and their families. In Geauga, our over 60 population is going to grow from 22% to 30% by 2030. Our under 19 and under population is going to drop to 19% or less. So we're going to have less folks that we're going to be able to prepare to get out into the workforce. So taking care of your employees now and their families is really, really important in connecting them to services. This just gives a quick run through of where we get the most of our calls from. When someone calls 211, we search by zip code so that we can give them the closest services in proximity to where they live. Should they say, I don't want to go to that food pantry because that's my church, then we'll go to another food pantry. But this database is not only local resources, now 26 counties worth of resources, but state and federal resources as well. So there's things that are just beyond our local communities. So you can call 211. Our 211 has a chat feature at 211oh.org, which is available. We have that available during our business hours from 9 to 5. So someone can go on and chat with 211. Here in Lake County, they do have a way that you can go on, the website's up there, where you can actually search for services and resources in the community. This is a challenge, so if that woman would have gone on here and looked for furniture, she would have found furniture, but she probably wouldn't have gotten the other resources. So having that navigation feature is really important. There's also a 211.org. So you have family member or employees who have family members that live out of state or out of town. You can go on here to 211.org and get connected to the 211, and that covers their community. Just wanted to touch on some special initiatives because I think this always sparks some ideas for people on how they can partner with 211. Bank of America, during the height of the foreclosure crisis, partnered with 211 so they could work with individuals who were really transitioning out of home ownership. The Centers for Disease Control had a contract with 211 when we had the flu epidemic scare, and so that they would be able to triage individuals and families so people weren't walking into a doctor's office sick. They could actually do that over the phone with 211. Recently, United Way of Greater Cleveland just received an accountable health community grant through Medicaid, and they are working with hospitals in the Cleveland area to look at embedding navigation specialists into the hospitals. Joining the UH board has been incredibly eye-opening for me in that in our U.S. healthcare system, our hospitals spend more money on the social needs and issues because people are coming back because of environmental issues, inability to access healthy food, inability to purchase their medications. And so we're spending more money in our hospital systems on those types of things that could keep people healthy if they had answers to those or solutions to those issues. So that's exactly what this project is going to do, really look at can the navigation specialists help individuals access the resources and services that they need to help them stay healthy. Locally, I'm just going to touch on really quick a reentry project. We have a navigation specialist embedded in our jail in Geauga County. This is a new project, and the Cleveland Foundation is funding this with us. It's been amazing because we have been able to work with treatment providers in the community. Individuals come into jail, they get jail treatment by our wonderful, wonderful organization, Lake Geauga Recovery Centers. They get that service, and then when they leave the jail and want to go to inpatient treatment, oftentimes inpatient treatments will not take a patient who requires an injectable medication. So if you have diabetes and you need insulin, you're probably not getting into a treatment center. Because of this program, we were able to work with a treatment center to advocate on behalf of a client, work with their physician. They were able to work out an agreement, and we were able to get this individual into treatment. It was huge, a huge step. Okay, that's all I have.